Hi everyone, today I'm here with Dr. Lacha, a neuroradiologist, professor in the School of Medicine, who's been practicing the field for around 45 years.
That's right.
So thank you, Dr. Lacha, for being with us today.
Absolutely.
Could you briefly, before we go into more of the details of your experience, kind of explain what radiology is and the different subspecialties of radiology?
Sure. Radiology is a subspecialty that is really the word radiology is a bit of a misnomer. It's imaging. It's patient imaging. And the original concept of radiology, radio, waves, Röntgen, X-rays, all that kind of thing. But we do a lot of other things now, not just using X-rays. We use MR, for example, which is a magnetic flux, and pulses that are put in to the scanning area when the patient is within a magnetic flux. So that's not true radiology. It's not the same. We use ultrasound, which is different. So a lot of things that we use, like CT scanning or plain films, we use an X-ray tube. But other things like MR and ultrasound are really quite different. And then there's another whole category of imaging called nuclear medicine, where a radionuclide is injected into the body, and then scanning is done, and the information being put out of the body, whether they're gamma rays or similar, are picked up on a unit that is sensitive to the gamma rays. So there's a variety of things that we do that aren't true radiology in the old sense. CT's been around since 1973, when Hounsfield invented the technique. And MR has been around since the early 1980s, so that's quite a ways. I've been practicing since 73. So I came in just at the beginning of CT. I did my fellowship in Ann Arbor at the University of Michigan, when we basically neuroradiology at that time was a subspecialty that really did angiography, pneumoencephalography, which was the insulation of air up into the head or into the spinal canal to outline the brain substance, and nuclear medicine studies that were really pretty gross compared to what we do today. So neuroradiology was just evolving at that time as a specialty. Now, you asked about the various subspecialties of radiology. It's all broken up now into various subsegments, body parts, basically. So a neuroradiologist like myself would look at abnormalities of the brain, the spinal column and spinal cord, and what we call the head and neck, which is those structures that are external to the brain. So it would be the face and the neck down to about the clavicles. Below the clavicles is the chest. So we have chest radiologists, because that's a whole different grouping of diseases. We have abdominal imaging, which is vast and includes abnormalities of the liver, the pancreas, of the intestinal contents. So it would be stomach, small bowel, large bowel, that kind of thing. It would be abdominal imaging, abdomen and pelvis. So it would be pelvic structures, ovaries, prostate, bladder, kidneys, all those kinds of areas are the abdominal imagers. And then we have, like my own wife, musculoskeletal imaging, which is joints, soft tissues. She does a lot of interventional work with that. So she'll put a needle into any joint space that you could imagine, or any soft tissue, or deliver some kind of a therapeutic drug, or do a biopsy, or those kinds of things under image control. So we do those under CT or ultrasound. And then there's the field of interventional radiology, which is non-neuro intervention. So we talk about doing vascular studies, so patients who have, for example, blood vessel abnormalities and have a need for an angioplasty and stent to widen their arteries would have it done by an interventional radiologist. Interventional people also do work on the liver, so they'll do work on the biliary system. They'll put a needle in, they'll put a tubing in to shunt obstructions away from the liver. So they're kind of the people who do things to patients. There's a whole area of interventional neuroradiology also. I used to do that up through beginning in about 1975 and up through 2011. I did interventional neuroradiology in addition to diagnostic. And so my interventional was putting small catheters up and taking clots out of patients' arteries if they had had an acute stroke, or filling aneurysms full of metal coils to ablate their aneurysm so the patient didn't have to have a craniotomy to get rid of their aneurysm. So that's all interventional neuroradiology. So neuro is diagnostic and interventional. Another kind of radiology is pediatric. And so the peds people, for example, think that little kids are totally different from adults, from the adult population. But they want to look at everything in the peds patient. So they'll look at some neuro, some GI, some chest, some bone structures, et cetera, but all of the pediatric population. So radiology is divided all up into these multiple different areas. And I graduated from the University of Minnesota Medical School in 1968, and I was going to be a neurosurgeon. So I went to Yale, and I was going to be in their program, but I had a real problem because I couldn't do children. And I had almost lost my own firstborn back when I was a senior medical student in April of my last year. I almost quit. I was so distraught with my son's near death. But then I went to Yale. But then I found that I had this recurring problem. I would keep thinking about my own son every time we had a child for neurosurgical kind of work. And so I decided not to pursue that. And instead I went into neuroradiology, which was, if you will, the intellectual side. It was making all the diagnoses, doing some of the interventions, but doing it under image guidance, etc., but not necessarily having to deal with the children as patients. I could walk away from it. And so it's so important. You have to learn what you can handle, what you can't handle. For example, I could never be a peds oncologist with kids with cancer. Never. Could never even conceive of doing that kind of work. I would get too distraught. Some people don't like neuro because it's fine little millimeter things that if you don't get it right, the patient could die. Other people don't like chest because it's too nebulous. It's all little white gray things on a black background. So you kind of get used to what is it that you like to do. Do you like to investigate things like a Sherlock Holmes? Do you like to do things with your hands? Or do you want a kind of a combination of things to kind of keep you kind of busy but not bored? So one of my sons, my second son is OBGYN, but he likes the surgical part of it and the medical part of it and the, if you will, genetic, hereditary, all of that kind of concept, that part of it. And so he keeps himself intellectually stimulated with the multiple parts of OBGYN. So it's interesting to kind of figure out, what do you like about a particular area? Don't get trapped. If you get trapped into a subspecialty and you find you don't like it, you might be stuck there for the rest of your life, unless you went back to school.
So could you kind of walk us through a typical day in your life and how a radiologist day would be different from another specialty?
Sure. So, for example, we start the day here at UC Davis by looking at all of the emergency cases that came in overnight. We have a radiology resident that is there overnight. We as faculty go up to about 10 o'clock. We can read from home. We have these big computer systems at home. And we go up through about 10 o'clock, but then we go to bed, and we're only called if there's something that the radiology resident, either a third or a fourth year resident, cannot figure out, or if the clinician wants a faculty member's input, whatever. So the radiology resident is there all night long looking at these trauma cases, head trauma coming through the ER, all that kind of thing, cervical spine trauma, etc. Then we come in the next morning and we start looking at all of the emergency cases that have been done. And when we get done with that, we then go on to be looking at our inpatient population. Frequently, they're follow-up cases. So a patient might have come in 3 days ago with an intracranial hemorrhage, and so now we're following that hemorrhage. It may be that the patient, the surgeons decided not to operate on the patient or take the hemorrhage out or whatever. So we're following the patient to see what's happening with the hemorrhage. Other patients, before you, just about the time you were coming in, we were following a patient who did have a previous bleed, and the patient's arteries were clamping down, what we call vasospasm, because of the presence of the subarachnoid hemorrhage in the head. And so we were following the patient's vasospasm along to know whether or not we need to jump in, put a catheter up into the head, and infuse a vasoactive drug to widen those vessels. Then we also look at a lot of outpatient work. And so we'll be looking at a lot of lumbosacral or cervical spine, looking for discs, tight canals that are giving the patient a problem with ambulation, so-called spinal stenosis. We'll be looking at a lot of patients who present with headache, looking for a possible brain tumor, or an anomaly like a Chiari malformation. They were born with cerebellar tonsils too low, and then they're getting headaches because of that. So there's a lot of reasons to get a headache. So we evaluate patients with headache. We evaluate patients with acute stroke. We see patients who have sudden onset of neurological abnormality. We're looking for, if it was sudden, a hemorrhage, an acute ischemic stroke, in other words, no flow or no lack of oxygen to the brain. We'll be looking for patients who have a variety of cancers. It may be a primary cancer of the brain, it may be a cancer in the mouth, it may be metastatic from someplace else in the abdomen, for example, and the tumor has metastasized to the brain. So there's a lot of different kinds of things that we're looking for. It's a very intellectually stimulating subspecialty, because we're continually looking for a lot of different things. It's a very varied population. We're working with neurology, neurosurgery, orthopedics, pediatrics, frequently the endocrinology, looking for pituitary tumors. So we look at a whole variety of different things, and if we need to know almost, not quite as much as the clinician, but darn close, so that we can really recognize, for example, pituitary lesion, they think that the particular hormone is at a particular level. We'll go searching for a particular tumor that could be producing that. So it's an intellectually stimulating. It's you need a sharp eye. You need an ability to talk to those clinicians and really be one-on-one. I need to know almost as much neurosurgery as the neurosurgeon does. I need to understand what he knows and what he needs.
What types of personalities are best for radiology, and what tips do you give medical students to match into a good residency program in radiology?
Well, personality-wise, it's very varied. Some people think, well, we just like to sit in the dark and we're kind of introverted and we kind of sequester ourselves. It's really not true. I was going to be a surgeon. A lot of people who do what I do with the interventional side are pretty outgoing. And you have to be a bit outgoing if you're going to give all these conferences or if you're going to be talking to the clinicians all the time. They come down, they ask your advice for all kinds of things. I mean, they sometimes want your advice as to what is it and how do I treat it kind of approach. So an outgoing personality helps. And yet a Sherlock Holmes-like attitude. You want to understand. I saw a patient this morning, enhancement of the optic nerves, both sides, optic sheaths along the nerves and the nerves themselves. Nothing inside the head proper, only in the orbits. Very bizarre case. So I'm showing it to my various faculty members. None of us could figure out what this is. So I'm calling the emergency room, talking to the docs over there, saying, hey, this patient needs a lumbar puncture, and this could be leukemia, this could be sarcoid, this could be. In the meantime, the neurologists are seeing the patient, the eyeball people are seeing the patient. So I'm just as involved as they are. So you need that Sherlock Holmes approach to be a good radiologist. You want to figure out, what the heck are you looking at? What is the diagnosis here? That's a big part of it. Matching for a residency. You want a faculty that will read with you, not just set you in the room and let you read. That's not teaching. We read with our young people. We're there in the room. Some places, very notable university programs, they come in at 10, read for an hour, go off and write their papers. Come in at 2, sit with the residents again. They're there till 3, and then go off and do whatever. To me, that is a terrible residency. I don't care how famous the institution is. It's a bad residency program. You want your faculty members to be with you, reading with you, answering questions if you have them, teaching you on the fly.
And that's for choosing a residency program, but what about for medical students to get into a good radiology residency program? Do they need research or any other kind of experiences?
And the answer is yes and yes. Yes for everything. It's just like everything else in medicine. The harder you work, the more you're productive with research type papers, the more that you've done in terms of giving conferences, the better you look as a student, as a potential resident. And so I would say all of that is very helpful. And so when we see smart kids who know how to ask good questions and they read, that is the hardest thing today. With all due respect, young people tend not to read. They want this stuff brought up on the computer. I hate it. I want to see them reading articles. And then they can come back and say, yeah, but I looked at this article and you were talking about your eyeball case and I found this interesting case of this leukemic infiltration of the nerves. And I would say, that's a student that I really like.
So what's the most rewarding and challenging aspects of radiology?
Well, I would say the most rewarding from a diagnostic point of view is getting it right, getting a case right that is or was a difficult case. People might have really struggled with this case, but you have to approach every case as if this is your mom, and you're going to make the diagnosis what other people have not. That's huge. Rewarding from a therapeutic or interventional point of view, you can fix the patient. You can give that patient a way to handle his disease or her disease process without having to go to surgery, without having to take on a much more laborious kind of a procedure. You're there, you can fulfill it, you can get that patient up and walking or moving or something with much less of a chore on that patient. That's very rewarding.
And what's the most challenging aspect?
Keeping up with, I would say, with all of the technology. In neuroradiology in particular, you really, really got to read. You really, really got to stay with the knowledge base, because we're continually adding new pulsing sequences for MR, for example. We're seeing new ways of looking at diseases. You've got to stay with it. You have to. You cannot just say, okay, I've got my residency. Fine, now I'm going to float. Not in neuro. You don't float. You got to stay with it.
And how do you keep up? Is it mostly just reading journal articles or conferences and things like that?
Yeah, so a lot of it is conferencing. So you can go to your society meetings, etc. I personally am of the opinion that all of this CME stuff will change, because it's getting to be that there's no point in spending $5,000 to fly to Seattle, Washington, to sit and listen to a 20-minute talk, when I can go online and I can spend an hour listening and going through that same material and get a heck of a lot more out of it. I think we're going to change how we do conferencing, and I've made that suggestion to my own neuro people national.
Are there any misconceptions about radiology?
Well, some people think that radiologists, just read them and next. And unfortunately, in our society right now, we've gotten to the point of, oh my God, I've got to read those 120 cases today before I go home so that I can keep up my salary, or I can do the volume that's coming in. And that's a terrible way to practice radiology. My wife and I hate it. We're kind of slow. We take our time. We look at that case. You got to pretend it's mom. And so you don't want to be too fast, because if you're fast, you miss.
How do you avoid burnout and establish a work-life balance?
Well, the life balance is, I'm in academia. And so my life balance is that I've got enough time to do research. I've got enough time. I've got at least 1 or 1.5 academic days a week, so that I can take a little bit of time and do something else, or I can do my research, or I can do reading papers, or whatever, on my day and a half per week. And I can also have a happy balance. I work from 8 to 5. I usually don't work much beyond that. I take call once every 6 weeks. So it's a reasonable balance.
And what employment types are there for radiologists, and how well are they compensated compared to other specialties?
Radiology is highly compensated. It's one of the highest compensated groups. Pediatricians don't make any money. Internists make a little bit of money, but not a lot. Internists are absolutely getting pushed like radiology. If a radiologist is being told to read 120 cases a day, the internist is being told you got 6 minutes to see a patient. It's just horrific what we're doing to medicine today compared to when I started. And so sometimes you just have to say, no, I'm not going to do that. No, I'm not going to go that fast. I need to spend some extra time. That's sometimes a bit of a challenge.
Would you choose the same career path again, or is there anything you change about it?
No, I like what I've done. I've been very happy with it. I've done all sides. I've done diagnostic and see the evolution from plain films through CT, MR, interventional. I've been here for the whole gamut. I could write a book about what's changed. And I started as an assistant professor. I became a full professor. I've been in 4 different universities. I've been president of the American Society of Neuroradiology. I've been a chairman of a huge radiology department. So I have done all of those different things that an academician can do. Written 4 books actually, 4 books and 700 articles and papers and all that kind of jazz. So I've done all that. So I have nothing that I wouldn't that I would say, oh my God, oh my God, it's terrible. I mean, no, I've loved my life.
And last question, what tips would you give us to become good doctors?
Well, I think it's that investigative, that Sherlock approach. To be a good doc, you gotta really try to listen to the patient. Most of the time, they'll tell you what's wrong if you just listen, and don't be so sure that you know better than that patient. You'd be surprised what the patient knows. And so the best docs are those that listen. The best docs listen to their colleagues. They're not so arrogant that they're going to do it all themselves. They know. The average orthopod comes down. He doesn't need radiology. Sorry. Yes, you do. The best neurosurgeons that I know come down and go over cases. And a very famous guy told me one time, he said, you make me look smart, because I'll go back to the patient and I'll tell them da-da-da-da-da-da-da-da, and it just makes me look great. That's a good doc. That's a good doc because he's using his colleagues.
Okay, great advice. So thank you, Dr. Lacha, for being with us today. Thank you guys for watching. If you have any questions, leave it down below in the comment section. Thank you guys again for watching. Have a great rest of your day.